a very difficult way. It's a kind of a difficult concept to understand that, okay, if my host response is working properly, why is it destroying certain things in the mouth? It is its job to take care of or kill the bacteria. Meanwhile, if a part of your body is going to get destroyed because of that, it's okay.
So you said plaque biofilm plus human response is what causes tissue destruction.
Correct.
Okay.
For instance, you and I contract the same virus. Okay? It's a flu. You stay in bed for 3 weeks, very sick. I stay in bed for 2 days and I start. That is the role that my immune response played in the duration and the severity of it. You are more susceptible. You didn't have a very active or very strong immune system. As a result, you really were not there. Does that make sense? That's why sometimes some people do develop periodontitis after gingivitis, sometimes they don't, because of their host response. Are we good with this? I'm sorry?
Human response is what
The
causes
human
tissue
response.
destruction.
Yeah. Because its major job, or actually I should say its only job, to save me as a host. Meanwhile, if my tooth fall off, I don't care, right? Okay. In the instance of periodontal disease, the immune response tries to defend the body against bacteria that is in the plaque biofilm. Since its job, see, that's their employment, right? Their job is to save me. They don't care if they preserve the tooth and the structure around it. Okay? That is why we lose those structures. Virulence factor, please know what the meaning of this is. All the mechanisms that enable biofilm to colonize and damage. Meaning these are the factors that make a bacteria pathogenic, correct? Because if they are not pathogenic, they are not going to destroy, correct? These factors may be either structural characteristics of a bacterium or the substances that they produce. Sometimes they have these enzymes that they produce, that those enzymes cause the problem. But sometimes it's their structural characteristics. The primary bacterial virulence factor that can enhance the damage, one of them is the presence of lipopolysaccharides, or LPS. It's an endotoxin that is in the outer membrane of gram-negative bacteria. This can start or initiate the inflammation. Their ability to invade tissue, bacteria such as P. gingivalis and good old AA, and when they are able to produce enzymes such as collagenases or proteases. This one degrades the host proteins and kills the structure around it. Then it is either the presence of the lipopolysaccharides. You remember we said either it is the structural characteristic, which is that, or the enzymes that they produce. Some factors influence the host susceptibility. How do they influence it? They modify the response or tissue metabolism. Either it's genetic, or environmental, or acquired. Environmental, tobacco, correct? Because of smoking, our PMNs become very, very decreased. They cannot phagocyte as much as they should, vascularity decreases, and the T and B lymphocytes, they cannot respond as well as they should. How many of you have seen patients who are smokers here? Okay, have you seen how fibrotic the tissue is? When you probe, they don't bleed as much, correct? And the tissue, by just the first glance, looks pretty. It's pink, isn't it? Maybe a little bit light purplish, correct? That is what it is, because it decreases the vascularity. It's a vasoconstrictor, smoking, okay? It is genetic. Certain syndromes like Papillon-Lefèvre syndrome or leukocyte adhesion deficiency, these are based on genetic predispositions. And acquired, that is a disease that we get, such as diabetes. Diabetes is a little bit tricky because controlled diabetes has no bearing whatsoever on periodontitis. Does that make sense? If I am a diabetic, but my HbA1c is 6.2, meaning it is very, very nicely controlled, I am not in a higher risk compared to Vanessa, who is non-diabetic. However, if my diabetes is not controlled, I am 3 times higher risk as she is. Does that make sense? Mm-hmm. Make sure you understand it is the uncontrolled diabetes that makes the problem more. What does diabetes do? Uncontrolled, it reduces the PMN function, increases interleukin-1 and prostaglandin E2. We will talk about these mediators. These mediators play a huge role in destroying connective tissue and destroying the bone. Acute inflammation is the first line of defense. These are the first kind of a barrier that show up and tell your body that, okay, this certain area is being invaded. After the plaque biofilm has been removed and this invasion has been taken care of, the host must be able to shut down the response, meaning the immune response. When the acute inflammation goes away, then your host response is not as active. Periodontitis is associated with unresolved inflammation. Why is that? Because periodontitis is a chronic disease, isn't it? Correct? It is a chronic disease. It is a disease that, since there is no pain involved with it, you might have it for 20 years and you won't even know it. Because it is chronic, it is slow growing. Resolution of infection is an actively regulated biologic process, meaning that if the immune response works properly, it should shut itself down after the inflammation is resolved. When we go back to homeostasis, that specific time, the phrase that is used is catabasis. First, you are in homeostasis, right? Then everything goes out of balance, and inflammation occurs. Body starts defending itself, but when we go back to homeostasis, the word changes into catabasis. And the process of catabasis is as complicated as the process of beginning of inflammation. Pro-inflammatory mediators such as PMNs are recruited. Who recruits these? The immune response, right? It says, come on guys, I'm being invaded, I need some soldiers to come fight, right? Those are pro-inflammatory mediators. Overproduction of these cause destruction of the connective tissue and resorption of the bone. Why is that? Because me, as a host response, I'm trying to save my host. Meanwhile, if the connective tissue and the bone are destroyed, so be it. Pro-resolving lipid mediators are produced to terminate the PMN recruitment. This is when they are trying to do what? They are trying to resolve the inflammation, and they are trying to go back to the status of what? Catabasis, correct? What do? They terminate the recruitment of PMN because they don't need any soldiers, the war is over. Somebody lost, somebody won. They stimulate macrophages. What do? They are eating everything away, right? They will eat away the dead cells, they remove them. They promote antibacterial activities. They want to get rid of them, correct? And they promote tissue repair and regeneration because they want to go back to the homeostasis. Does that make sense? It is a full circle, right? This should be a part of microbiology, isn't it? Or in biology. Somewhere you have already gotten this. Chronic inflammation, on the other hand, happens when the host is not able to stop this recruitment. And this infection goes on and on and on, but it is at a very slow rate and it becomes a chronic issue. Hence, periodontitis is a chronic disease.
One question.
Yes?
On that previous slide when we talked about homeostasis,
Uh-huh.
the homeostasis isn't always a positive.
It is. It is a state of balance.
I know, but if somebody's already unhealthy
Okay.
and you control it and you get them back to their version of homeostasis,
That is catalyst. It becomes, the word changes
That's
into
their
catalyst.
norm.
That is their norm. Yeah. Because anytime you are, everything is in a balance in your body, you are at a state of homeostasis.
Right.
Status quo, everything is good. But when something happens as inflammation and kind of tips that balance,
Yeah.
then we start having inflammation. Then if body is, the host response is active enough and is able to take care of inflammation and shut itself off, we go back by the process of catabasis to homeostasis.
Okay.
Make sense?
Yeah.
Okay. Yes, ma'am.
Sorry. Okay, so the chronic inflammation that it being unable makes it be chronic.
Yeah, the body cannot shut it completely off. It stays there. It is not as active, however, it cannot stop the inflammation. And it cannot stop the host response to kind of cease, right?
Yes.
They are still fighting, but they are not fighting effectively. If you look at this diagram, it's whatever we talked about, this one is showing it. From microbial invasion to the next response, which is acute inflammation. Either the host response can resolve the issue, right? This is the green, correct? And goes down and everything returns to the homeostasis. But if the inflammation is not resolved, then we go to what? We go to chronic inflammation, correct? And these are the diseases that are chronic diseases. Periodontal disease, diabetes, cardiovascular disease, rheumatoid arthritis, chronic obstructive pulmonary disease or COPD, neurological disorder, and organ fibrosis. Does that make sense to you? My poor mother has one of these. She has cardiovascular disease. It is a chronic disease. It has affected her periodontium a little bit, but
You can never get rid of it, right?
no.
It's like.
You have to take medication for the rest of your life, and that is something that keeps it as a chronic disease. It doesn't make
But
it
not worse.
correct. It doesn't, it kind of controls it. Okay? Yeah. All right, now we get to nitty-gritty and we get to the interesting part. Biochemical mediators are biologically active compounds. They are secreted by immune cells. As a result of this secretion, what do? They activate the body's inflammatory response. These are biochemical mediators. There are many of them. In Perio, we are interested in 3 of them only. These are the 3 that we are interested. These are middlemen, okay? Middlemen are sent to immune cells to activate the inflammatory response. These are the 3 that are very important in periodontal disease. Cytokines or cytokines, however you want to pronounce it, is fine. Prostaglandins, matrix metalloproteinases, or MMPs. These 3 are of importance to us.
Does everybody have them?
Yeah, everybody has them. It depends how they are secreted and how much of it is. Okay? Because these are the mediators. They kind of activate the immune system. They are good things, but too much of them is not good. Yeah. Okay, guys, you need to know these 3 very well. Very well. Cytokines, or the meaning of it is cell proteins. These are powerful mediators. They are produced by immune cells, and these immune cells are the ones that influence the behavior of other cells. They signal to the immune system to send more phagocytes to the infection site. They are produced by many different cells: PMNs, macrophages, B leukocytes, epithelial cells, gingival fibroblasts, and osteoblasts. They are produced in response to tissue injury. And the ones that are very important to us, because they do have a major role in periodontal disease, are interleukin-1, interleukin-6, 8, and TNF-alpha. These are the ones that we need to know for the purpose of our class and the purpose of our test. Interleukin-1, 6, TNF, which is tumor necrosis factor. This is a cell signaling protein, alpha. Are you with me? Okay. What are the functions? They recruit PMNs and macrophages to infection sites. They increase vascular permeability. What does it do? It allows the movement of immune cells into the tissue. However, they can initiate tissue destruction and bone loss. In chronic infections, one of them is what? Periodontal disease. They can initiate tissue destruction and bone loss. The second one is what? Prostaglandins. There are many different series, D, E, F, G, H, and I. E series is the most important to us when we are talking about periodontal disease. These are, again, powerful inflammatory mediators. They are derived from fatty acids on the surface of the most of the cells. Most cells can produce prostaglandins.
You want us to remember all of them or just E?
E. Just if you see those letters, you know they are not cytokines, right? Because they are interleukin 1, 6, and 8.
Right.
These categories are the categories specifically designated to prostaglandins The most important one for us is E. And look at that. It plays an important role in bone destruction. What these cytokines do, they can initiate tissue destruction, right? Prostaglandins series E or E series, what does it do? It destroys bone. Are we good? You're gonna see these guys. You need to know all these. The function of them, they increase permeability. Anytime that we have infection, they increase that permeability. It becomes vasodilated. Why? Because it wants those cells to get in the tissue. That inflammation, that edema that you see in gingiva, what does it tell you? It tells you that the immune response is working. It has become edematous. Why? Because it wants to increase vascularity and allow these cells to come in, go out, come in, go out, okay? And they trigger osteoclasts. We know the difference between blast and clast, right? Blast is building block, clast just destroys it, right? Prostaglandins, they trigger osteoclasts. As a result, they destroy the alveolar bone. And they promote overproduction of NMP enzymes. And NMP enzymes, they are good enzymes. In health, what do? They facilitate the reproduction. It's like when you shed skin, you know, we shed skin, right? NMP in health causes that shedding. It is healthy, but overproduction of it causes what? Breakdown of connective tissue matrix. Their family is at least 12 different enzymes. Thank God you don't need to know all about that. Just know that these enzymes act together and they break down connective tissue matrix. Okay. What do cytokines do? Initiate the tissue destruction. Prostaglandin E series destroy the bone. MMP destroys the connective tissue matrix. You need to know these three. Okay? When we are at the last stage, which is periodontitis, which biochemical mediator is seen everywhere subgingival? I'm talking about periodontitis. What happens in periodontitis? What is the difference between periodontitis and gingivitis? Bone loss. Okay, if bone loss is that determining factor, what of these mediators you see the most? Prostaglandin. Very good. Okay? The function of MMPs in health, they facilitate normal turnover of periodontal connective tissue matrix. But when there is overproduction of it, what does it do? It destroys the connective tissue. Are you all good? Okie dokie. In chronic bacterial infection, MMPs are released. They are released in order to kill the invading bacteria. As a result, the overproduction of it breaks down the connective tissue of the periodontium. The high level of it results in extensive collagen destruction. Most of the connective tissue is made up of collagen, right, in periodontal tissue. Without collagen, the tissue of gingiva, periodontal ligament, and supporting alveolar bone degrades, and the result is gingival recession, pocket formation, and tooth mobility. Why? Because The bone has been destroyed, periodontal ligament is gone, and connective tissue is kind of like a mush. There's no collagen, not those, you remember those cable-looking rods that were going all over the place in connective tissue, that is gone. Are we good so far? I know it's a lot of material, however, if you make sense of it, you will remember these. Okay. Current theory of pathogenesis. What did we say pathogenesis was? Very good. Progression of the disease. At this point, pathogenesis that leads from top to gingivitis to periodontitis. It is very complex and multi-layered. What type of a disease is periodontitis? Chronic, and it's a mixed infection, right? Correct? Because we don't know how many of these bacteria cause that, right? It's so many different bacteria. Microbial infection activates the host response. Genetic and environmental factors modify the inflammatory response, right? Genetic certain things, behavioral is what? Like environmental, smoking, right? And mediators are produced by cells of the inflammatory response. This is the current theory of the disease process in periodontitis. Are we good so far? Okay. Now let's look at the histologic stages. This is a chapter that is full of information, and you need to know a lot of it. Okay? Then if I ever tell you you need to know this, means that you will see this over and over and over. In private practice, in national board, in your exams. All right, there are 4 histologic stages in development of periodontal disease. Initial lesion, early lesion, established lesion, and advanced lesion. The first 3 constitute what? Gingivitis. The last one, advanced lesion, is Perio Ch. Are we good? Initial lesion, another name for it is bacterial accumulation. You need to know which one is which. There are times that the question might say initial lesion or it's a bacterial accumulation. Please make sure you understand that initial lesion is the same as bacterial accumulation, okay? Bacteria colonize teeth near gingival margin. The gram-negative bacteria and their metabolites start the host response. Junctional epithelium cells release those mediators to start the immune response. They wake them up and tell them, okay, get back to work. And they recruit PMNs to the site. PMNs were those inflammatory response that would come and take care of the disease, right? PMNs go through the blood vessel. How do they go through the blood vessel? What happens to the blood vessels? Vasodilation, correct? Increases in size and increases in vascularity, because this way these cells can pass through. They go through the blood vessels and they get into gingival connective tissue. And when they pass through, what do? They release cytokines. This is initial lesion. Are we good? Your book has beautiful pictures, and I have them right here as well. We will look at it and you'll understand it a little bit better. The initial location is at gingival margin. It is still what? Supra. Gingival margin, right? It hasn't seeped to become sub. curvicular fluid increases in volume. Anytime we have infection, we have more curvicular fluid or gingival curvicular fluid or sulcular fluid. Clinically, tissue looks healthy. You look at it, it's pretty pink, right? Host response is successful if most of the bacteria are destroyed. And the body can repair the damage. This is what? Gingivitis, right? Beginning of gingivitis. As a result, if the host response worked well, everything is gone, body can repair itself, and if these pathogenesis or these pathogens are not destroyed, we go from initial phase to the next phase, which is early gingivitis. Are we good? This is the picture that I'm talking about. The colonization of bacteria is near the gingival margin. We have vascularity, increased vascular dilation, and PMNs go through the blood vessels and get to the gingival sulcus. Are we good? Okay. Now, if the body is not strong enough, the host response is not strong enough and cannot kill the bacteria, we move from initial stage to what? Early lesion, or initial lesion to early lesion, and that is early gingivitis. The biofilm maturates, and those bacterial toxins and byproducts penetrate junction of epithelium. Cytokines attract more defenders to the site. Okay, we have more invaders. Come on, fight. Come and kill them. Again, we have more permeability of blood vessel, allows more PMNs to go, and they become like a wall. These PMNs become like a wall between the biofilm and the circular epithelium. Okay? It is trying to tell you, it's kind of a mental image that there are so many of PMNs that they create that wall. PMNs, again, release cytokines, cause localized destruction of connective tissue. Macrophages are recruited to the connective tissue. They release more cytokines and MMPs. MMPs are responsible for extensive loss of connective tissue. We said it is causing the connective tissue destruction, 60 to 70%. And the circular epithelium forms those ridges. Do you remember in health, the circular epithelium had a straight or very soft type of an interface with connective tissue? Whenever it became diseased, it started having those ridges. Those are the epithelial ridges. Yes?
So in early,
It is still kind of trying to get it. It is still in the sulcus. Okay? Clinically, edema and redness is shown. When the patient opens his or her mouth, you can see inflammation and redness. With initial lesion, it looked healthy, correct? With early lesion or early gingivitis, you will see that change. The body still can repair the damage, and if the immune system fails to shut it down, what happens? We progress from early gingivitis to established gingivitis. If you look at this picture, do you see more PMNs? Do you see that wall? And you see those epithelial ridges are forming, and you see more microorganisms floating around. Have a mental image here, guys, or keep it on your iPad and look at this one. Do you see that? You see the difference? In early gingivitis, there are so many of them. disrupts the attachment, but the coronal most portion of junctional epithelium from the tooth surface, and more bacteria stimulate more cytokines. It's a vicious cycle. More of everything. We have more PMNs, macrophages, lymphocytes. Plasma cells produce large quantities of antibodies. This way they can help in killing or controlling bacteria. Immune system sends more immune cells. As a result, they release toxic chemicals, and because of this toxicity, more healthy connective tissue is destroyed. You will see those ridges become deeper and deeper, extending to the connective tissue. Junctional epithelium loosens its attachment, and it goes to the root surface. And at this point, the sulcus becomes what? A pocket epithelium. Thinner, more permeable. Clinically, you will see everything is exhausted. Periodontal instrumentation and patient education at this point is enough, and it can take care of itself. However, if we cannot take care of it and the body cannot fight it, what does it go? It becomes periodontitis. However, the reason that not all gingivitis cases become periodontitis is what? Because the immune response completely shuts it off, right? But if the immune response is not adequate enough, the patient might turn from gingivitis to a periodontitis patient. Are we good, guys? Okay. Look at this. Everybody is joining the party. And you see how deep those ridges are becoming? And you see a lot of cytokines, a lot of prostaglandins, a lot of NPPs. Everything is there. These are toxic chemicals, right? Okay, have that mental image, but do you see that the junctional epithelium is still on the tooth? You see that? But it is kind of getting a little bit closer to the root surface, because this is established gingivitis. Advanced lesion, another name for it, periodontitis. At this point, the biofilm spreads laterally and apically. Apically, laterally goes to the connective tissue, apically it goes to the root of the tooth. It can harm the periodontium. At this point, we are talking about the other three members of periodontium, right? The first one was gingival only. PMNs, macrophages, cause destruction of connective tissue and PDL fibers, and there is a higher concentration of cytokines, prostaglandin, E series, 2, and MMP. Hand in hand, they destroy the bone.
So the established region is probably go up to like maybe 4 millimeters, but not deeper, and then
Correct.
for advanced would probably be like around 4 or
Now
maybe
5, 6.
beyond, right?
Yeah.
Okay.
Because at that point, we have lost the attachment.
Okay.
Gingival pocket changes into periodontal pocket. We know the difference between pocket and sulcus, right? Pocket is a disease sulcus. We do have gingival pocket, that 4 millimeter or 5 millimeter pseudo pocket with bleeding that you see, that is a gingival pocket. But when it starts going deeper and it shows bone loss, then at that point it is a periodontal pocket. Prostaglandin E series 2 destroys bone because it stimulates a large number of osteoclasts, and they start from the crestal of the alveolar bone. Elevated levels of rank L They get together with the osteoblasts and they start destroying more bone. And the destruction caused by post-immune response overwhelms any tissue repair. At this point, there is no return. Okay? Clinically, periodontal pockets are detached. There's bleeding upon probing. We see bone loss on X-ray, percussion involvements, and mobility. Tissue changes are not reversible because these changes are in the tissue, correct? That is a hallmark of periodontitis. That's the difference between periodontitis and tissue. These are the factors that will influence the host failure. One of them is abnormal human function, persistent and virulence of bacteria in the biofilm, meaning we have not been able to remove them, acquired and environmental factors such as smoking and stress, and systemic factors. One of them is uncontrolled diabetes or genetic factors. These become more challenging and make things worse. Look at this one.
Oh, wow.
And at this point, you see junctional epithelium is sitting on the cementa, PDA is gone, you see that? Alveolar, the crest of alveolar bone is gone, those ridges, my, everywhere, and look at the number of bacteria. The accumulation is outrageous at that point. And since prostaglandin has initiated the process of destruction, bone destruction, osteoclasts have been modified by rank and rank L, and they cause more bone loss. I think these pictures are very helpful. To me, they are, because I'm very visual. Okay.
I have a question.
Yes.
It's kind of a little bit off the same thing, but for gingivitis, for a pseudo pocket, what would be the deepest pseudo pocket?
It's a very difficult.
If you can't put
Well,
6
you
millimeters.
can. You know why? If you have an umbilical, that can be 6 millimeters.
There's not like a set.
But a 7, you have to look at the situation.
Okay.
If there is no umbilical, a 6 millimeter pocket is no longer gingivitis.
Okay.
But if you see huge inflammation,
Yeah.
and there is no bone loss, that 6 millimeter pocket is a
It's a
pseudo
pseudo
pocket.
pocket, okay.
You have to look at so many things.
Okay.
Just the presence of pocket or the number associated with it
Yeah, it's not enough.
is not enough. That's why you have so many other tools hand in hand, allowing you to make an educated guess. Okay? Are we good here? This part of it is a little bit confusing. However, there is one specific slide that I want you guys to know. The rest of it, if you are a microbiologist or if you are a specialist in rank L and rank, you're not going to figure it out. Okay? Despite its solid appearance, bone is in constant state of remodeling, right? Yes. Okay. We lose bone, we remodel it. We lose bone, we remodel it. Okay? This one is only telling you what happens when that remodeling cannot catch up to when we lose the bone. Are we good? Okay. This is the physiology of normal alveolar bone. We have osteoclasts that break down the bone matrix. We have osteoblasts that, what do? They synthesize collagen and other type of bone proteins. Then this bone remodeling is coordinated by these two, the interaction that osteoclasts and osteoblasts have together. The bone remodeling cycle, please know these 4 cycles. Resorption phase is when osteoclasts are numerous and they create that cavity, that erosion cavity in the bone. Reversal phase, when osteogenic signals bring the make the osteoclasts stop working, and what do they bring? They bring osteoclasts. They send signals, they bring osteoclasts, osteoblasts. This way osteoblasts start the formation phase where they line this eroded cavity and they start replacing the bone that has been resolved. Resting phase is when nothing is happening. There is a ceasefire, there is no interaction between osteoclasts and osteoblasts. Then resorption, we have more osteoclasts, right? Reversal, we have what? More osteoblasts. Then we get into formation phase and then we rest. Are we good? This is just a pictorial depiction of what we just talked about. Resorption, you have more osteoclasts, you see that? Reversal, the osteoclasts stop acting, right? They cease their action. Osteoclasts conjoin, and then at the formation cycle, they start filling that erosion, and then we go to rest. The mechanism of body, human body, is just fascinating. All right, this is where it becomes a little bit confusing. Rank L, rank and OPG, this is a pathway. This pathway, I think, came about, they discovered it, I think in 1990s or 80s, let me look at the notes here. That tells me the exact year. In 1990, the discovery of this rank L, rank and OPG pathway, they discovered it in 1990s, and they have understood. There was a huge leap in science that they understood these 4 different stages and 4 different phases. Rank L is not a good guy. Rank L is that cell membrane bound protein on the surface of an osteoblast. However, it regulates the maturation of osteoclasts. Rank by itself is the cell receptor. That is a precursor for osteoclastic activities. And then OPG, or osteoprotegerin, that is a soluble secreted protein that is released by osteoblasts. This one, particular one, protects the bone from resorption. Okay? They're what? Yeah, you need to know that, but this is what you need to know about them. Rank L, rank, and OPG. This is a pathway. This is a signaling mechanism that happens between the osteoclastic precursors and osteoblasts. What are those precursors? Rank and rank L. OPG is a good guy who wants to preserve the bone, right? Okay. Rank L binds to rank. It signals the osteoclastic precursors, and they become osteoclasts. They resorb the bone. The cumulative effect of rank L and rank together, when they kind of get together, is bone resorption. OPG blocks this binding. What does it do? It blocks itself to rank L. When OPG binds to rank L, there is no bone resorption. This is all you need to know, this one. If rank L binds to OPG, bone is protected. If rank L binds to rank, bone is resolved. When the ratio of OPG to rank L is higher, then osteoclasts, they do what? osteoblasts start building the bone, right? But if the ratio is low, what happens? The osteoclast starts taking over. Then in homeostasis, the body tries to have a balance between OPG and rank L. But when this homeostasis goes away and we don't have the balance, what happens? We start having bone resorption. Then in periodontal disease, what do we have more of? Rank L and rank, because they start destroying the bone by producing mature osteoclasts. And the number of osteoblasts are not as much. Are we good? This is the only thing you need to know. When rank L binds to OPG, bone is protected. When rank L binds to rank, it is resorption. And when these two are in the state of homeostasis, nothing happens, right? There's a balance between OPG and rank L. Body tries to keep that balance. But when that balance tips over to rank L, what happens? Rank L and rank cause osteoclasts to mature and start eating away the bone. This is the simplest way I can explain this to you. This is exactly what we talked about when there is a bone resorption versus bone formation. You see that? And this one is just showing you when the rank L and rank get together and OPG is just around there and doesn't get together with rank L, osteoclasts become mature and they start eating away at the bone. Do you think this is the process that happens when we are at the resorption phase? Yes. Right? Because at the resorption phase, what do? We have more erosion in the bone. Then the OPG attaches itself to rank L, and then we start doing what? We start the formation phase. It should make sense when you look at it this way, right?
So OPG, if I touch it to bring L.
Yeah, when OPG attaches itself to rank L, we have more osteoblasts and bone starts forming. Yeah, but when rank L and rank get together,
They destroy.
yeah, because they initiate the maturation of osteoclasts and they start eating the bone and destroying it.
Thank you.
You're welcome. All right, guys, you need a break. I need a break from speaking. Go ahead. Right now we have, based on this one, why don't you come back? How about 12 minutes or so? 20 minutes to 3? Is that good? 20 to 3? Okay.